TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are here in Orlando, Florida for Anesthesiology 2019, the annual meeting of the American Society of Anesthesiologists. With over 14,000 delegates, this is the largest gathering of anesthesiologists and anesthesia providers in the world. Now, I'm joined by my co-host, editor-in-chief, Monty Mythen. Hello, Monty.
Hey, Desiree. Great to be here.
Yeah, it is great to be here. Day 3. We're almost through it.
And so far, I have not seen a Disney character, so that's good.
Except for the ears that you made me wear yesterday. They made me put on mini ears yesterday, which...
They're around somewhere.
Yeah,
I thought they were being sported by Henry.
There are pictures, and it's on Twitter. So if you're dying to see that, that's where you can find it. Monty, it is good to be here. Day 3 at ASA, but this is actually our third year.
Yep.
Here.
Boston, San Francisco, and now Orlando, Florida.
Right. And we want to thank our sponsors for everything that they have done for us this year to get us here to the ASA and support Edwards and support us getting free open access medical education to the world.
Yeah, we often get asked how we manage to fund this. So we do it with grant funding predominantly. And some of those grant funders are industry partners. And Edwards Life Sciences has been very generous in supporting us to be here. You can find our other funders via the website, etc. But we couldn't do it without the grant support. That's what keeps it free, open access.
Absolutely. And we want to say thank you to the ASA, the Society, for just giving us general support throughout the meeting. We really appreciate the engagement and helping us share the knowledge that we gain through our conversations we have here with the Globe. So thank you very much to them. Now, we have had some great conversations over the past couple days. A lot of them, pertain to enhanced recovery, change management, implementation, fluids, hemodynamics. And we talked to Lifebox, which was the NGO, and a great organization that you should definitely look up.
Effectively a charity supporting global safe surgery.
Yes.
Really worth having a look at.
Yeah, it was a great conversation we had last night. So, but we're going to switch gears a little bit, and we have a superstar of TopMedTalk here with us this afternoon, or this morning, Lee Fleisher from the University of Pennsylvania. Lee, I don't know if you know this or not, but you have made the top editor's pick of TopMedTalk for 2020.
Well, that is fantastic, and it is always exciting. I wake up at 4:30 in the morning, I go to my phone, and I get a notification that there's a new download available.
Yeah.
And I download every day.
Right.
And it's fantastic. And trying to get my residents to do the same.
That's what we were just saying. We need to develop a residency type of list.
Well, I think they can just listen to what all of it. It's really quite wonderful.
I've had a number of people now sneak up to and sort of say, that stuff you were talking about came up in the exam,
Oh, yeah, we have had. Yeah. Henry can
attest
to that, too. So, well, Lee, thank you so much for joining us. We've had lots of great conversations over the last couple years about really hot topics in the anesthesia world, in the healthcare world, really. And when we were trying to figure out what we wanted to talk about today, we went through, brain health, some of the things that we talk a lot about. One of the things that we haven't visited in a while is the alternative payment models and some of the way that works, I can't talk specifically here in the U.S. So tell me a little bit about where we are right now and some of the things that you are working on.
So it's fascinating what's going on because we keep saying we're going to go to value-based care rather than volume-based care and get away from fee-for-service, and it's happened slower than many of us thought, except in North Carolina where it's going much faster because of relationships between the state and Blue Cross of North Carolina. But what I'm hearing, and I'm getting involved in Washington on this, is that this administration is saying we've got to get to what is called downside risk. So the idea that, in the past, what they did, and it was really an interesting story, if I might, because in mid-1990s, they said, we now pay for the hospitalization, and basically you, hospital, have to figure out what's going on. And then in 1999, they tried an experiment. And it was to combine the hospital and the doctors, and that was bundled care. And it never got implemented, even though I reviewed like 30 applications for CMS, or HICV at the time, because of Y2K, which some of you listeners
probably
don't
millennials.
Yeah.
Well, the millennials probably don't even know what that is.
But because they were afraid that they couldn't pay for it. But it really has come into fruition where you pay the doctors and the hospitals and post-acute care for 90 days of care, and saying you'll get one price and you figure it out. And it started with one price and if you save money, you made half of that extra money or a percentage. But CMS and now the private payers are really saying, look, we're not going to give you any raises in money. You're going to have to earn it. So, in fact, Monty, you were phenomenal work in ERAS. They're all interested.
Yeah.
Because the idea is if they can shorten length of stay, if costs can go down, they save it. So bundles have, now that there's a downside, which is protected, because if, for example, we had an incredibly expensive hip fracture patient because they had hemophilia. So there are certain exclusions. So for a while, they were just letting you keep the upside risk. Now they're saying you've got to take the downside risk. So we anesthesiologists can really help by trying to reduce the total cost of care. And what's been interesting is I'm listening out of D.C. and I'm on a panel on Thursday, is what if we move the question upstream? And I think the UK, you've done it better than anyone in that, the Walmarts and Virginia Mason has done this on the other side. But the new question is, wouldn't it be cheaper not to do low-value surgery, to not operate on patients who don't need their laminectomy because they could be managed better by exercise or rehab, who don't need to, and Virginia Mason does second opinions. You guys say maybe they shouldn't have that cancer surgery because they'll get no longevity in life. So the things that they are very interested in, and we're going to talk about on Thursday with CMS, is what if we go upstream, starting with back pain, and you get paid for the whole episode, including deciding whether or not you should operate.
Just a couple of little international translations. So CMS is
the Center for Medicare and Medicaid Services. So most of the world doesn't have private insurance.
Yep.
They have it paid for by the government. So in the U.S., everyone over 65 and anyone with disabilities who qualify, it gets paid for by the government, and that's the Center for Medicare and Medicaid Services.
That's taxation, so it's your national health service.
It's our national health service for elderly patients.
And the thing that you mentioned that something had changed in North Carolina that's accelerated the process.
Well, we have Saul here, so he may know. So
Blue Cross Blue Shield is an insurer?
Is a private insurer in the state. They had a visionary leader for a while. He unfortunately
had a moment of
step down.
Yeah.
But he was previously at Medicare, at our national insurer, and he really said to Duke and UNC is you've got to take more and more risk, and you've got to take care of more of the population.
The upside on the risk is if you deliver very high value care, you've got a margin. Is that right?
You've got a larger margin.
So
Saul Aronson, thank you for joining us.
Sorry, I'm coming in late.
You're good.
Indeed, and I think, Pat Conway, who had to step down for other reasons, but came to North Carolina a few years ago with a very, very aggressive agenda to make the state at least 50% risk-bearing within years of his arrival. And it sort of metaphorically shook the state up, grabbed us by our shoulders and gave us a little shake. And made us appreciate how vulnerable we are as a healthcare system to the whim of a payer to change their attitudes and force us to think about our readiness to be risk, if you will, viable. And that said, I thought you were actually also going to add on top of that the North Carolina State Treasurer, who was going to force us to take a significant cut and tether, if you will, our reimbursement to a Medicare rate that was significantly discounted than we were used to. Another, if you will, sort of moment of aha in shaking us up. Both of those underscore the proposition that value is really something that we have to be prepared to deliver. I think, if I may, value is a really important term, and we have to deliver that. I think it's really important when we speak amongst ourselves and we talk about the opportunities, and we publish about the waste in medicine, and of the $3.5 trillion that we spend, that maybe 20% of it is attributable to waste. That doesn't mean that we should discount the cost of care by 20%. It means we should expect to get 20% more value out of the current cost. Yeah. And that's a very important differentiator that we have to stress to the politics who make policy.
But the interesting question is, post-operatively, do you need that expensive care that you have? I mean, the biggest change has been we probably use rehab much less.
I was going to say, like skilled nursing facilities and rehab. Yeah.
And how do we figure that out? What is going to be very disruptive in the United States is CVS, which is our big drug chain, and they're going to set up minute clinics. There's a guy named Troy Brennan there that essentially you don't need to go see the doctor. Now, the thing we have to figure out, because you can go see...
But isn't that already happening?
Yeah, but they're going to expand nationally.
I mean, like there's the Walgreens clinics, there's Kroger clinics. Like, we have that a lot. I mean, is that just going to be the standard of care for like a primary care?
Well, we have to now show, and I'd be curious what Saul has to think about this, and whether you've seen it in the UK, we have to show that maybe for routine care, you have a cold, you go to the minute clinic. But if you have a chronic disease, you can't be managed in a minute clinic. You really need a integrated health system which is on one electronic medical record, which really can follow you, because it's really those readmissions that add up costs.
I violently agree with that. I think the pressure of the free market will drive us to get our wellness care at Walmart and CVS, right. and I would argue, and it should, and on the other hand, there's a tranche of us who have stable chronic medical disease that need to be managed in a environment that is beyond that. But healthy people don't need anything other than wellness care that they can get in a retail outlet. The poorly managed chronic comorbid medical conditions are the population that is costing us and driving the cost of care disproportionately greater than everybody else. We know that. And I think our ability to manage that population well is going to be challenged, and appropriately so. And the role of what we do upstream and downstreamly is something we need to focus on.
And the big win for everyone here is to see these changes as opportunities. And if you don't see them as opportunities, they will be a big threat. It's a bit like the adapting. It's inevitable. This has to happen.
So, Lee, how does all this fit into these models that CMS is looking at?
Well, I think what's going to happen is the meeting which Mark McClellan from your institution, formerly heading Medicare, part of it is going to be going upstream and asking, when you get a diagnosis of disease, can you manage the disease rather than can you manage the surgery? So asking the question, I mean, in some ways we need to learn from you, Monty. We need to learn, CPET, and is this patient really the right patient to not have palliation versus non-curative, curative surgery?
Yeah. Well, the example you gave is an excellent example. Is back pain.
Yes,
you get a bundled payment for managing back pain, not just for doing surgery.
Correct. Yeah. And that's that is the one that we'll be discussing on Thursday. The other real question is, can you manage a population? So in Maryland, the hospitals get one budget for manage the population in their state, and keeping people healthier is a good thing.
I have people ask this a lot. Is that considered capitation? Is that kind of, sort of?
Well, what they've done is everybody hated in the 90s, wouldn't you say, Saul, 2000s, of capitation. They've flipped it around and say, we're going to do population health. It's sort of, instead of the insurance company owning what you're allowed to do, they make the health system own what you're going to be allowed to do.
The buzzword is total cost of care, two-sided risk.
Yes.
And that's, if you will, the acronym that we should be speaking to, because it's the way...
Say it one more time.
Total cost of care, which is disease across the entire horizontal continuum, and two-sided risk, which
sort
is
of like a trust.
Yeah.
Lee, your point about we as a part of the broader healthcare delivery system need to be more focused on disease management, bending the curve, and even retarding the progression of disease within any tranche, if you will. But that being said, we are where we are. There are people who have healthcare that is managed. There are people who have healthcare that is poorly managed, and there are people that have healthcare that isn't managed at all. And often, their first touch point to a healthcare system is when they have to confront the reality that they need surgery. And so in our domain, in the perioperative domain, that's a reality. And I think what we can do through a little bit of a more narrow lens, but still in the context of population, is to recognize that if you need surgery, you need surgery. Emergency and urgency notwithstanding, those are dealt with emergently and urgently. But if you need surgery, you need surgery. But you shouldn't have surgery until you're ready to have surgery. And to your example earlier, and maybe you shouldn't have surgery. And I think that's a different paradigm shift that we have to approach.
So, the interesting question, I spent most of my career on pre-op cardiac evaluation. I think it will all be blown away with two words, frailty and sarcopenia. I think that if we start to understand what frailty really means and detecting them as part of our pre-op evaluation, sarcopenia being even worse, that those are the patients that it's going to make a difference to get them in great shape. Don't need all the fancy tests.
So I'm going to push back a little bit, only because I have data.
That's good to hear your data.
That's always dangerous. That, of course, frailty and sarcopenia is a probably most sensitive metric of frailty that we're only beginning now to appreciate and learn how to measure more efficiently. There still are chronic comorbid medical conditions that portend increased adverse outcomes. Anemia is an example that I think we're all much more sensitized to, but poorly controlled diabetes or undiagnosed diabetes, nutrition health, shy of sarcopenia, if you will, and on and on. And I think all those chronic comorbid conditions absolutely contribute to a adverse outcome that is not just health related, but also measured with health economic, if you will, metrics of length of stay, readmission, and ED visits within a perioperative domain. And I think if we address those proactively, actually I will say
put a plug for your.
I know that if we address those proactively, we can significantly reduce the cost of care.
So I'm very jealous of what you have at Duke. You know that I would love to do something like that. And so one of the things that I think is going to happen is in 30 days, you are going to see some difference. And in fact, we published just 3 days ago in Annals of Surgery a paper that showed that academic medical centers have lower mortality only than for sicker patients. We actually, for healthy patients, teaching hospitals, no different than non-teaching hospitals for surgery, general surgery. Orthopedics, it doesn't make a difference where you go. But as patients get sicker, the teaching hospitals, in-hospital mortality is higher, but their 30-day mortality is lower. And I think it's the extra resources that we do for these very sick patients.
It's very cool data. It's a competitive advantage for academic institutions that may be the niche that defines our differential.
But that says that for commodity care, for people who are relatively healthy, we need to figure out how to deliver that care cheaper and devote the resources to the sicker patients. So, but if we start extending out to 90 days, which then these costs of what you do will clearly be seen.
Yeah. Cool data.
Well, on that note, Lee, I want to thank you so much. As usual, it's always a fantastic conversation. Please, if you haven't already, subscribe to Top Med Talk. You can do that on TopMedTalk.com. We will send you a newsletter. I promise it's not invasive. What it really does is send you an email that tells you how to sign up for Top Med Talk, how to get it delivered to your favorite podcatcher or our app every day of the week. And it really helps us, too, whenever you subscribe. So please do that. Help us out there. Share with your friends. Share with your residents if you have them listening.
Then, like Dr. Fleisher, you can wake up to that little ping every morning.
Every morning. I know I do. And so, yeah, that would be great. Thank you so much for that. Monty, tell them also what we're offering whenever you get the new
our new box sets, which we've been promoting. So we bundle together some little sets. One's the perioperative coach through the perioperative continuum. So you have a nice little taster, do a few car journeys, whatever you want to do. And the other one is our top picks, which includes
Lee Fleisher
is in there, along with President Clinton, for example.
There you go, Lee.
I'm honored.
Also, if you subscribe to Top Med Talk during this weekend, you will enter a chance to win our beautiful bespoke Marshall amp. If you're watching on Twitter, hello there, Twitter world. But we do offer our Marshall Bluetooth speaker, and it's a beautiful little thing that I had to buy one after last year when we gave one away because I loved it.
They're very, very cool.
It is very cool. So thanks again for listening. We're going to be up again at 11 o'clock with Greg Fisher. Lee,
always a pleasure.
Thank you so much.
Thanks, Lee.
Cheers.
Top Med Talk.
Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.TopMedTalk.com.